Hi, I'm Maureen Donohoe. I'm a physical therapist at the DuPont Hospital for Children. I've been working in the Arthrogryposis clinic for more than half my life. I'm really excited to be asked to participate in the virtual Arthrogryposis meeting this year. I'm really sad that we're not together, but I'm glad that I can share some information to help you guys be smarter about what you do. So today we're going to talk about feet, and I'm going to review some basic anatomy so you have a better understanding what happens with foot deformity. We're going to talk about some of the basic foot deformities that occur with arthrogryposis and identify some stretching strategies to help maintain flexibility. So what are the most common foot issues? Clubfoot is the most common. I would say that arthrogryposis, there's probably 85 to 90% have some sort of foot deformity, and clubfoot is the most common. Then there's vertical talus and there's oblique talus. Before we get started, I want to say thank you for the pictures. So I have sought out the illustrious Wikipedia to find some pictures of bones and muscles that would help with detailing what we're doing. I want to thank the Polygon Body Parts 3D because we use them a lot for this talk. And then I use GT simulators, and of course I have an amazing group of patients that were more than willing to help me out this week in getting some videos done. Thank you. So the foot has 28 bones and 30 joints. We're going to talk about the bones. The foot can be divided into the hindfoot, the midfoot, and the forefoot. And in the hindfoot, there's two bones. There's the talus, which happens to be my favorite bone in the body. It has no muscular attachments. It attaches to everything in the foot via ligament, bone to bone, and it influences the entire shape of the foot. It has a trapezoid-shaped top. Let me see if I can make this bigger so we can talk about it a little more. So it has a trapezoid-shaped top, and either side of it should fit between the lumps of your bones for your ankle. If it doesn't fit in there and left unchecked, the front of it can get wider than the back of it. So it will continue to grow while the person grows. And if it's not held in the spot that it's supposed to, it will deform and become different from what it should be. Therefore, it won't align up and get into joint if we don't get it tucked in early in life. So we like to. Let's see if I can get back to the, there. The other bone of the foot is the hind foot is the calcaneus. It's also known as your heel bone. And it's this big broad bone, and your talus, this purple bone on top of it, sits on top of the calcaneus. And it is how the foot is named. So if it's turned in, such as in a clubfoot deformity, it's called in a varus position. Clubfoot is often known as an equinovarus deformity. And it's also associated with a high arched foot, a varus deformity. If it turns outwards or in valgus, such as in an oblique talus or a vertical talus, it is also associated with a really flat foot. The midfoot has 5 bones. There's the navicular that lines up with the head of the talus if the talus is lined up correctly. There's the cuboid, which is on the outside of the foot that sits behind the base of the 5th metatarsal. And often, if you have a clubfoot, there is a prominent bone that comes out. And kids that have relapsing club feet that have been tight will often come in and there's a big bursa over top of this. And when we do casting, sometimes that becomes uncomfortable. And then there's the cuboids, and a bunch of muscles attached to the cuboids. And this tends to be a very stiff area of the foot. And I often like to get that moving and grooving before we get the whole foot stretching. So we'll go over that at some point in this talk. And then the forefoot has 21 bones. The metatarsals, there's 5 of them. And then there's the bones of the toes, and there's 14 of those. Big toe only has 2, everybody else has 3. And then there's 2 floating bones called sesame bones that are under your big toe. After we look at bones, there's muscles. There's over 20 muscles that work together to create optimal foot alignment and function in the typically developing foot. Let's talk about where they are and what they do, so that way when we talk about what's overfiring or what's working, you have a little better idea of why it's influencing the foot alignment. So the muscles that point the toe down, the main ones are the gastrocnemius and the soleus, or the gastroc-soleus complex. The gastroc crosses the knee, so it bends the knee and points the toe. The soleus just points the toe. There are other muscles that point the foot down, but these are the main players. And when we talk about management of some of the foot deformities, they often talk about doing a tendo-Achilles lengthening, and they do it someplace down around this area, and it's to lengthen the muscle to be able to bring the foot up in a better alignment. In a clubfoot, the soleus tends to be the tightest muscle that influences the alignment of the hind foot in a clubfoot. And I often will spend a lot of time teaching families how to stretch that muscle. There's muscles that pull the foot in, and if you have a clubfoot deformity, it tends to be the bane of your existence. Let's see if I can do this. So the anterior tibialis comes into the front and attaches to the base of the first metatarsal and the navicular. The posterior tib goes underneath the foot and attaches to the bottom of the cuboids, but it also tends to pull in. And then the great toe extensor, so the big toe that points up. And any of my friends who know me, when the baby comes in, if they have a big toe that sticks up, I'll say, oh, that toe, it's going to be the bane of my existence, because often that toe tightness really does influence how the foot pulls in. And so I try to work really hard to stretch it in. Let's see if I can get back to my original view again. I apologize for my flunky work here. This is all new learning for me. Okay, so there are muscles that push the foot out, and they're called the peroneals, the peroneus longus, brevis, and tertius, and they tend to run on the outside of the foot. If you have a vertical talus, it tends to be a very strong muscle. If you have a clubfoot, the foot tends to be put it on stretch, and it makes it hard for those muscles to find how they're supposed to work. And these muscles are really important for strengthening when it comes to a clubfoot, because they help hold the foot in a neutral alignment. Muscles that bring the foot up. A lot of times when we have kids that have club feet, they point down, and it's a hard time to get them to pull their feet up because their bones aren't in the right alignment to get those muscles to work together to pull the foot up. But we use the anterior tibialis, the great toe extensors, and there's the brevis and the longus. I just have pictures of longus, and the little toe extensors, and there's the longus and the brevis. Now, if you have an oblique talus or a vertical talus, these muscles tend to be really strong, and they work really hard, which is then yet another problem when it comes to stretching them down. So something to consider when you're thinking about foot deformity. The other part is not really a muscle, but it's soft tissue in the foot, and it's called the plantar fascia. And the plantar fascia is this big, heavy, fibrous ligament that it goes from the toes to the heel, and it tends to be shortened often if you have a foot deformity, and it creates a bigger arch than you need. And when you think about it, it holds the arch, but if you bring your toe up, it makes the arch that much bigger. And a lot of times, can you see how toes down flat, it's kind of on stretch, toe goes up, and it goes really on stretch. In individuals that have club feet, this plantar fascia can be very tight, and many times we'll hear about plantar fascia lengthenings and things like that. I like to try to get this stretched out as much as possible because it helps the foot move a little more smoothly. So arthrogrypotic foot muscles are different from everybody else because a lot of times they're either really weak or they don't work at all, and sometimes muscles are missing completely. When the bones aren't in the right alignment, the muscles don't work efficiently to help assist the foot. So if they're not in the right alignment and they're weak, they have no hope of working efficiently. The interesting thing is a lot of times when we get the foot into a better alignment, the muscles work a little bit better than they did before. And I can tell you stories of kids in their teens who have had major foot surgery and all of a sudden they have muscle strength they didn't own before because their bones are in the right space. I find that toe flexors, the muscles that bend the toes, that squeeze the feet, tend to be a real challenge for me because they pull the foot down and in. And a lot of times, some of my kids with amyoplasia will have really strong toe flexors and not much else. And they use those toe flexors for balance. But that use of toe flexors for balance also makes it so they're strengthening the wrong things and pulling their foot in. I call it using your toes for evil. And those tight toe flexors sometimes will make it hard to sit in a brace comfortably because they just don't want to relax and stretch. It's always important to try to get the best alignment so you can strengthen the muscles to support holding that alignment over time. And we start early, we start often, and we try to keep it going. So let's talk about the most common foot issues in arthrogryposis. So the oblique talus, it's typically not a surgical candidate, but it is of concern. It corrects well with casting, but it gives you a really flat foot alignment. And let me see what, so here is the typical bones of a foot. They kind of line up, you have a nice arch. The talus lines up with the navicular, and it seems to be okay. In an oblique talus, it's just a little bit off. It's a little off center, and so it doesn't line up quite right, and it gives you a flatter foot. And this is my friend who came out of a cast yesterday in time for his birthday, his first birthday. And you can see his foot alignment's not so bad. His toes are a little crisscross applesauce, but I believe that will stretch out nicely over time. But he is a little bit tight through his forefoot. And my next slide will show you the stretches that I showed them to do. Let's see if I can get there. So you can see I'm kind of wiggle, wiggle, wiggle. And I don't go right for what we're going after. I don't go right to the spots that I want to stretch. I start around it. I play with the toes. I play with the midfoot. I try to get things, it's soft tissue to stretch. I look at the creases and stretch the skin. You can see on, let me go back this. Can you see that tendon pop? That is his peroneals. And that muscle is really strong that will help pull the foot out. So I want to stretch that a little bit too. The other foot is a vertical talus, and you can see there's a little divot where the navicular should be sitting. And so we'll look at that one next, the vertical talus. Now, my friend, when he was born, had his foot all the way up to his shin bone. Usually vertical talus is associated with some genetic form of arthrogryposis, and casting will help to get it in a little better alignment, but often you're going to need some sort of surgical intervention to get the bones from sitting where they typically sit to from go back. Sorry guys, if we were doing this in real life, we would be going through the same things. So in a vertical talus, what happens is that talus bone dumps down between the navicular and the calcaneus. And so the forefoot tends to go up over top of the talus. And so with the vertical talus, we cast it down and in to try to get it in a little better alignment. And if you look at my friend, he has these really deep creases because he was really pulled up high against that, and his foot goes outwards, and we were trying to cast him down and in. When it's time to go stretching on this foot, we're going to go after those creases first, because those creases are tight skin as well as tight muscles. So we want to loosen up the skin a little bit before we get going. So let me see if I can get to our video at this point. So here we are stretching the creases out, trying to get that soft tissue to open up, bringing the heel around towards the inside of his foot. Luckily, we just came out of casts. That foot is coming down nicely, but the outside of his foot still tends to turn outwards. So we're pulling him in and trying to encourage that foot to curve in and create a bit of an arch. I'm also stretching his big toe down because he wants to go up with his toes. Stretching those toe extensors down a little bit too. So the clubfoot is the next foot deformity, and it's the most common. It's the rotation of the talus. Again, we're going to look at the normal talus, and then we're going to look at the clubfoot talus. This is a bone model that was designed by Dr. Ponsetti, and it is missing the toes. So we're just looking at the hindfoot, the midfoot, and the metatarsals, not looking at the toes. But you can see that the talus is really turned outwards and the heel is turned inwards. Okay. So clubfoot management in the past involved big open procedures that sometimes had the talus removed to get the best alignment. When I first started working in the clubfoot clinic, we did not do Ponsetti method, and that was over 20 years ago. And we would do big open posterior medial lateral releases, and it left the child with a very small foot. It did a nice job of getting the foot in a good alignment, but it was a stiff foot and it was a small foot. And so we found that you got a lot of arthritic changes over time. So about 15 years ago, we started doing Ponsetti method in our clinic, and it really is the most common first line of action for managing club feet. And often there's casting and then a tendon lengthening surgery to get the foot in the best alignment. And then the feet are held in some sort of containment, either an AFO and or foot abduction brace for a period of time to hold the alignment over time. We try really hard to do less invasive surgeries because it results in less foot stiffness over time. But sometimes big surgeries are needed for feet that relapse frequently and are hard to get comfortable in a brace. Some kids just really have tough feet. Sometimes the top looks okay, but the bottom tells the story. So here is my friend who came to see me the other day, and she was telling me that her feet hurt. And she looks really nice in her brace. Side of the foot looks good. I mean, it's not bad alignment. Front, who wouldn't love to have a foot that looked like that? But then the bottom, she's having a lot of discomfort right through here. And one of the things that we found was that she was really tight through her plantar fascia, and then she was substituting across the lateral surface of her foot and getting significant brace rub because of it. So you could have a foot that looks like really nice, but still not have a comfortable foot. So here's a video of me doing some of the Ponseti stretches, just so you can see what it looks like on the bones. We'll go through some of the stretches too, but I wanted you to see bony what I'm expecting you to happen. And you can see you can get that talus tucked in. The hind foot goes from varus to neutral once you get it all tucked in and in the right position. And here's the foot unchecked, and then with the talus tucked in the right position. You can see the unchecked foot, the talus isn't underneath the ankle bones, and then you can see it's really well covered within the ankle, in the mortise joint. So I apologize for the lousy camera angles. The camera person or my camera skills are not that great, but it gives you an idea of what I'm trying to do on a child in the next video. I want you to see how I'm mobilizing every single bone to make sure that things are gliding and moving. I'm doing things in rotations and trying to move things around because I want to make sure that we're loose before we start trying to push hard. And you can see the foot doesn't go straight across a straight line. It kind of rocks and rolls across the bones. And then we'll do the same thing with my friend who came in the other day. Moving that foot around. Again, I apologize for the lousy camera person who happens to be me. And I'm wiggling. My video's getting glitchy. I apologize. Trying to wiggle that first ray, get that big toe to loosen up a little bit. Because remember, those big toes can really influence the entire shape of the foot at times. And then you can see my thumb is on top of his talus on the outside and trying to push that in while I'm trying to correct his foot alignment. Going after the heel. And this is why I usually don't do videos in my in-person talks, because things like this happen all the time to me. But you can see how you can kind of push on that talus and keep it moving outwards. Now, my friend also has some significant scars and creases. So I often will go in there and stretch the scars and creases before I go after the middle of the foot. I will go in there sometimes with some lotion. My favorite is cocoa butter. Or cocoa oil, coconut oil, where I get single packets from Trader Joe's and just squirt a little coconut oil on the foot and help to loosen up the tight scars with a little scar massage so it doesn't influence where the heel is going. Oh, going back. So my friend has a tight plantar fascia, and you can see she has a deep crease, and when I bring her foot up, her big toe drops because she's so tight. And this is my friend that had the bump on the bottom of her foot, and you look at the inside of her foot and it's just not exactly the way you would want it. So I'm going to stretch that by taking hold of the heel and pulling the heel away from the forefoot. And you can see she kind of blanches out, and you can almost see the tendon pop a little bit. And I actually want that to happen. I want to get a good stretch on it, and then I bring the big toe into the stretch so I get the foot as flat as possible, and then I stretch the big toe up because I want to stretch that plantar fascia. The other stretch I'm going to do is the soleus, and what I have her doing is lying on her belly with her knee bent, because when you're stretching the back of the calf, if you bend the knee, you get the soleus. If you leave the knee straight, you're getting gastroc. So I'm going to bend her knee. I'm going to pull on her heel. So I'm pulling her heel towards me and dipping the front of her foot gently down towards the floor. Not a big stretch at the forefoot, more of a pull at the hind foot, because I think that that does a nice job of isolating the soleus. The other thing I ask families to do, or if they have the ability, is to do what's called an Asian squat or a sumo wrestler squat, where you bring your toes out wide and you squat down and put your feet flat on the ground and just kind of hang out there, because that's a good soleus stretch too. So here's some take-home messages for you. It's never too early or too late in life to work on stretching. Arthritic changes in older feet feel better when there's a little more motion. So it's really important to get those little joints of the foot moving to help reduce the stress across the more uncomfortable joints. If you follow the creases and the scars, they're like your roadmap of what to stretch. So if you stretch those things out first, you get soft tissue and skin that's stretched out that will let everything else follow. Stretch the foot using rotation to start, allowing the bones to naturally roll across each other. You don't want to go in and go straight out to the side or straight up. You want to let the bones rock and roll. And if you need to go back and look at the video again on how the bones work, it might help you. Wiggle things before you jump into stretching what you really want to stretch. And I often will start doing things wiggly and fast because I want it to just loosen up before I go for that long stretch. Calluses tell you where the weight bearing's happening. If the calluses are uncomfortable, something needs to change. Now that may be a brace adjustment, it may be a different shoe, it may mean more stretching, it could mean a time for another round of casting, or worst case scenario, it could mean some surgical procedure. But let's try to get the feet comfortable and the calluses off weighted, so that way we can avoid anything big, bad, and scary. I want you all to remember that having a relapsed clubfoot is not a reflection on the parent or the child. With every growth spurt, the bones grow faster than the muscles, and the tight, soft tissues get tighter with that growth spurt. It takes a little time for it to catch up. Sometimes we have to cast to get the foot in a better alignment, but if we can stay on top of it and keep that foot braceable, we're reducing the need for surgical intervention, which is always my goal because I'm a physical therapist who hates surgery. Doing a little bit every day to help make everything a little more stretchy really counts. And if you're big enough and you have enough balance, doing some self-stretching is really important too. I have a picture of my favorite stretching tool, which is called the Pro Stretch, and it's kind of like a rocker board that you can put the foot on and rock it back, and it helps to get the plantar fascia. It helps to get the tendo Achilles stretched out. You can do it in shoes. You can do it in bare feet. The nice thing about the Pro Stretch is you can do it, and if you don't do it, you have this piece of equipment sitting around looking at you saying, did you stretch today? And not only the individual with arthrogryposis can use it, but the entire family can use it. More take-home messages. Stretching should be gentle and it should be part of routine. It should not create more stress. You know, if you go slow and you make it enjoyable, either incentivize it. You can play on my phone while I stretch your feet, which is like the bane, not one of my favorite things because I want kids off of technology, but we will often play with cars or with toys or puzzles to get the activity done. I have kids that come in that are really grumpy with me if we don't do stretching first because it feels good and it should be comfortable. Well, I find that sometimes I'll lotion kids up and I'll get them really slimy, and it feels good to be all lotioned up, gets the skin a little bit more mobile, but then I'll use like a washcloth or a towel to help get a better grip at the heel when I go to stretch that heel. It takes a good 20 minutes per foot to get your best strength and stretching alignment. And it's almost like you're working it, and then all of a sudden everything goes soft like butter and it just kind of moves, and you have to put a little bit of time into it. Sometimes when I have kids that are really fibrotic or have a lot of scar tissue that needs to be mobilized, I use these little tools called GUA. I looked it up today and it was $10 for a set of 3 on Amazon. And the nice thing about them is they're really small tools that are really used for like facials and things like that, but it's small enough for a foot, and you can kind of move the scar tissue and stretch the scar tissue and help loosen things up. And I find that it is quite helpful sometimes to get the foot moving a little bit better. So I have a message specifically to the adults and the older teens. Go get a pedicure. That could be the parent of the child with the arthrogryposis, or it could be the individual with arthrogryposis. You know, the massage chair feels good. It's relaxing. The whirlpool will make your feet feel nice. You'll get a good foot massage. They'll take care of your calluses and they'll trim your toenails. They will not judge you for how your feet look. And it's worth it because you're worth it. Thank you for inviting me to this virtual meeting. If you need to reach out to me, my email address is rdonohoe@nemours.org, and this is my home away from home. I look forward to seeing you in the near future. Thank you.